Welcome everybody to this week's ECG of the Week. Here's our clinical vignette from earlier on Facebook. Feel free to pause the video and remind yourself of the characteristics of this patient. Moving on to the ECG, it's very tempting to make a spot diagnosis, but once again, let's go through our 6 steps. So we'll start with rate. Let's zoom in here to the rhythm strip. We've got 2 nice beats right there, and let's count how many big boxes. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, just about 11 big boxes. So that's, about 27 beats per minute. Rhythm, this may be a bit challenging because this patient is so bradycardic, but if we used our paper method, we would see that this is indeed a regular rhythm. P waves. In multiple leads, we can clearly see that P waves are present. QRS. You can take any QRS here. We'll start at the beginning of the QRS wave and go to the end. And we count 1, 2, 3, 4. Now 4 is larger than 120 milliseconds. 4 is about 160 milliseconds, so we'll call this wide. If we went to PR interval, well, on our rhythm strip, we've got about 9 big boxes here, so that's very wide. However, if we go to the next beat, we can see about 14 big boxes. And if we go to the next beat, we can see 17 big boxes. And the next beat has no PR interval. So there's no real consistency or no real pattern. So we're going to call the PR interval irregular, but also wide. We'll keep a question mark next to that. ST segment. Isoelectric line is right there. ST segment there. No real changes, maybe ½ millimeter, but that's non-significant. Same thing in a different lead. So we'll call the ST segment normal. So what does this tell us about our clinical picture? Let's go into our summary of the ECG findings. So as I told you, our ventricular rate was 27 beats per minute, but if you go back to the ECG tracing, you'll see that the atrial rate is completely different, and that's 60 beats per minute. So what do we call that when we have a different ventricular rate to an atrial rate? The rhythm is regular. Notably, the pulse is maintained by the ventricular escape rhythm. P waves are present, but distinctly P waves are not present for every QRS complex. And this is the key to second and third degree AV block. So now we're getting a better picture of what's going on with this patient. QRS complexes are wide or over 120 milliseconds. The PR interval is variable. The P waves do not correspond to the QRS complexes, and that's because the ventricular and atrial rates are completely different. The ST segment is normal. The interpretation, therefore, is third degree AV block with ventricular escape rhythm, otherwise known as complete heart block. So what's the pathophysiology of third degree AV block? There's complete absence of conduction through the AV node. The atria and ventricle are acting completely independently of one another. The perfusing rhythm, that is the patient's pulse, is maintained by either a junctional or a ventricular escape rhythm. Patients in third degree AV block are at risk of entering ventricular standstill if the escape rhythms fail, and this leads to syncope or sudden cardiac death if the patient is not treated immediately. So what are some interpretation tips when faced with a patient that you suspect has third degree AV block? They'll often be in bradycardia, therefore less than 60 beats per minute. They will have a different atrial rate to ventricular rate, and those will be independent of one another. Each QRS complex is not preceded by a P wave, and the QRS complexes may be narrow or wide depending on where the escape rhythm is coming from. If it's junctional escape, the QRS will be narrow. If it's ventricular escape, the QRS will be wide. So let's take a look at some examples. Here's a third degree AV block with a ventricular escape rhythm. So as you can see, a very regular, there's a little P wave hidden in there, atrial rhythm, and a very different ventricular rhythm. You can use your paper method and see how regular the atrial rhythm is, and see not only is the ventricular rhythm much slower, but the width of those QRSs is much higher than normal, or above 120 milliseconds. Here's a third degree AV block with a junctional escape rhythm. So very similar to the previous patient. Let's mark out our P waves here, here. There's probably one buried under this T wave, and there's probably one buried right here, and there's another and another. So very regular atrial rhythm with a very different ventricular rhythm and no association. The reason why the QRS complexes here are narrow is because that escape rhythm is coming from the junction, and therefore using the conductive pathways of the heart. Here's a third degree AV block with a junctional escape rhythm as well. So you have to zoom in a little bit here to see the P waves, but they're visible. There's probably one somewhere under this T wave. There's one, and there's one. And then our R waves completely dissociated in time. Again, narrow QRS complexes because the escape rhythm is coming from the junction. So what are the takeaways for diagnosing AV block? If a patient is bradycardic, remember that heart block is a possible cause. Sometimes it can be tricky to pick up complete heart block because P waves look like they're lined up right before QRS complexes. So go step by step. Identify that the patient is bradycardic. Carefully look to make sure that every QRS complex has a P wave before it. If not, heart block is possible. Step 3. To exclude other kinds of heart block, make sure that the atrial and ventricular rhythms are completely dissociated and separate from one another. This is the most important point that distinguishes third degree AV block from the others. Step 4. If you've done that, applaud yourself for making a tough ECG diagnosis. Thanks for watching, and we'll see you on our next video.